So incontinence in women can be urinary incontinence, can be fecal incontinence, can be vaginal incontinence. We're going to speak about primarily urinary incontinence and fecal incontinence. So when we speak about urinary incontinence, extremely common problem. Say if we were to do a short questionnaire on all people in a room, about 50%, so half the people in a room would have had an episode of incontinence or struggle with incontinence. So it is just very common. So there are two types of urinary incontinence. One's urgency or urge incontinence, which is leakage when we have to rush to the toilet. And the other kind is stress urinary incontinence, when there is leakage, when the patient laughs or sneezes, there's involuntary leakage of urine. Next slide, please. Another type of incontinence is fecal incontinence. We have an international body for urogyne problems, and they say if a woman experiences incontinence of feces, either liquid or solid, at least once a month, then they're classed as having fecal incontinence. It is extremely distressing, as one can imagine, and it is pointed to a lot of systemic problems too. Next slide, please. So if you can imagine, that's a picture of the rectum and the anus, and then the anal opening through which the feces is expelled. And what's marked as external and internal are just a bulk of muscle, which is meant to help women keep the continence, meaning keep control. So when this doesn't work, fecal incontinence, flatus incontinence happens. Next slide, please. So why does it happen? Dr. Anand quite beautifully detailed about menopause and lack of estrogen and various reasons why UTIs happen. So similar reasons actually, but commonest cause of incontinence is childbirth. And a lot of patients quite rightly ask, childbirth happened 20 years ago and I didn't have a problem then, doctor, so what now? I'm in my 40s and why do I have all the incontinence now? And it's because of a combination of factors. When you're young, the various other muscles and nerves make up for the loss of muscle tone in the pelvic floor. And so you're able to keep continent. Whereas with time, and when these muscles lose their actual strength, the incontinence happens. Next slide, please. So age is a huge factor. So when I said the incidence of urinary incontinence is about 40 to 50%, it's mostly in women over the age of 40. In women who are younger than 40, the chances of somebody having urinary incontinence is much lower, almost half that. Next slide, please. Again, menopause, very, very, very common problem. And it's not perceived as a problem. I have patients in clinic who ask me, but doctor, what is menopause? So what if my period stop? I'm quite happy. But menopause has, has a way of slowly growing into you. It's not a disease. It is not cancer, but it can cause quite a lot of symptoms. And one of the earliest symptoms is urogenital aging, meaning a loss of ability to control the bladder, the bowel, and a bit of redness, a bit of burning. So quite a lot of urogenital symptoms, quite a lot of bladder genital symptoms really, along with a little bit of flushing, some mood changes, loss of memory, irritability. It causes quite a lot of problems, and if attended to, can be taken care of quite easily. Next slide, please. So quality of life. The reason I put this slide here is like I said, urinary incontinence, fecal incontinence is not cancer, but it affects quality of life significantly. And a lot of people ask me, a lot of friends, family ask me, yes, I've had a little bit of incontinence, but when should I seek treatment? When should I go to a doctor? If it affects your quality of life. Yeah, as women, we're all very tolerant. We change things around a lot for other people, but these changes should not affect your quality of life, meaning, just to concentrate on the last 2 points here, mobility. I've had a patient who lost a job as a secretary in an office because of urinary incontinence. She could not get from home to the office, which was a 20-minute walk, because she had urgency. She had to pass urine all the time. And in her office, she kept going to the toilet, and a boss just thought she was, finding ways to avoid work. Now, culture and leisure, again, I have lots of patients who are, can we go back to, can we stay on the slide for a minute, please? Yeah, I have lots of patients who love to do the music and their sabas in the winter and the rest of it. And they have a real problem because one, like Dr. Anand mentioned, not many facilities have a good toilet. And if you have a real problem holding your bladder and you have to be in and out of an auditorium, you can imagine what it can do to your entire evening. Now, these problems should never stop you from enjoying life, over and above what you have to do on a daily basis. Next slide, please. So what is the real cause for urinary incontinence? The main cause is urogenital aging, meaning weakness of the pelvic floor muscles and ligaments and not holding the bladder and vagina and bowel like it should. But what are the other causes? I don't think we need to go through this in too much detail because it's been beautifully covered already. Early infection. Commonest cause of urinary incontinence is an infection. So when my patients come to clinic, I always check them for an infection. Systemic illnesses, a very first sign of diabetes, sometimes first sign of a mild renal problem, which can sometimes be completely asymptomatic. Worsening neuropathy. I'm sure you've seen the, low backache, joint pains are very common in our country. And I'm sure you've seen a friend, a family member who has a little bit of pain in the back, and then it slowly starts getting worse. They're still limping around. They're just limiting their mobility, not getting help. And it can sometimes compress the nerve and cause problems with the bladder. Yeah. Now, the other very common thing that we see in clinic is when women come to clinic, they have a real bad problem with their bladder. They're either not able to pass urine, they just lose control of their bladder completely, or they have an urgency and I have to go every 5-10 minutes. And this has all just happened 6 months ago. And quite often we find that there's maybe a mass, an ovarian cyst, which they've been completely symptom-free from, or a large fibroid that has not caused any problems so far, that is suddenly increased in size, that needs attended to. There are some people that have other pelvic masses, such as like an inflammatory bowel disease, an inflammatory mass, things like that. So urinary incontinence actually opens up an opportunity to investigate for various other things and make sure there's nothing else wrong going on with you and with your body. And of course, the biggest thing we are all worried about is cancer. So if you've had that little bit blood in your urine, a little bit bleeding per vaginum, it's always important that you're investigated. Next slide, please. So where CURI is just perfect to have your urinary. I'm not just saying that because I work there, but they have all the facilities, and a lot of the corporates do not have all the facilities to investigate urinary problems completely. We have a good urodynamic setup, good facilities to have cystoscopy, good availability of pelvic floor physiotherapists, everything we need to treat urinary incontinence. Next slide, please. So why not? So when I was at this panel discussion, one patient quite interestingly asked me, yes, I have a little bit of urinary incontinence, but I don't want to go to the doctor because one, I don't want to be shoved into a room and be told I need surgery. And the next thing I know, my entire family is descending upon me and they're all worried about me. And I just don't want to go through that. So what if I have a little bit of urinary incontinence and I'll just wait and see if I can manage it the way I'm managing it now, the way, like some people don't drink enough water, then end up with other problems. Some people stop going out, stop doing things they love. And then they end up with problems with mobility. Some people stop doing their jogs and their walks and their swimming, and because of urinary incontinence, and that gives rise to other problems such as high cholesterol and hypertension. So an early opportunity is lost. And the other thing about coming in and having this set of assessment and investigation at an early stage is minimally invasive and very minimal intervention. For instance, small operations, pelvic floor physiotherapy, mild medication, good physiotherapy will all make you feel better. And you can carry on with, as normal as possible for the rest of your life. So that is the advantage of early intervention. Whereas when a patient comes with quite severe incontinence, it is invariably surgery. And surgery needs to be quite advanced and quite thorough. It is, again, like Dr. Ananthakrishnan quite clearly and beautifully demonstrated, it is now a lot more easier, done with a lot more precision. So therefore it is less painful, less hospital stay, and it's not such a big deal. But if you can avoid it, that I'm sure we all agree is the best way forward. Next slide, please. Right. So what for? Why? Again, this was one of the other questions. So what happens when I come to the clinic? If you're saying, okay, we're not going to shove surgery down your throat, it's not what we're going to advise everybody. What else? Lifestyle modification. Now, the commonest lifestyle modification that I talk about, that I almost bully everybody into adopting, is reducing the number of teas and coffees that we drink. I'm a culprit myself, so I cannot do without my teas and coffees myself. So, but a lot of people who drink a lot of teas and coffees have significant urgency of the bladder. Now, this kind of, the incidence of this increases with age. Again, it's compounding factors, but you'll find that if you reduce the amount of teas and coffees that one drinks, the urgent incontinence definitely reduces. Of course, the other culprits are citrusy drinks and colas that a lot of people don't tend to do, and most people that I see are reasonably healthy with regarding to carbonated drinks and the rest of it. Just an interesting story, and I always quote the story when I talk about lifestyle modification. I had a patient who was actually very healthy, took care of her diet so well, went on a regular walks. She took care of herself and her husband really well. Now, she had started drinking green tea as a health drive to lose weight and to keep active. And she hadn't put the two together. And this had happened a few days, or maybe a few weeks after she'd started a green tea. And then she started having quite bad incontinence. So tea, even if it's green tea, can cause bladder irritation. So the herbal teas are quite good. Milk is quite good. Any kind of other fruit juices other than the citrus juices are quite good. All our soups are really good, but we have to avoid what we call the bladder irritants. Again, weight loss. Very, very commonly observed in the over 40s and 50s, when women just slowly start to put on a lot of weight, and because of the pressure on the pelvic floor. If you look at the picture accompanying this slide, there's a little red diaphragm just below the bladder, uterus, vagina, and the bowel, and that is what we call the pelvic floor. So the more weight one puts on, the more pressure on the pelvic floor, and the less it's able to hold everything up. Estrogen supplementation, again, there's estrogen receptors along the bladder wall, along the vagina, and sometimes giving patients a little bit of estrogen, just cures the patient of bladder problems. And physiotherapy is very, very important. So this pelvic floor, this hammock that you see, has lost all tone. Just like, say, your biceps or triceps has lost all tone because it's not been used for a long period of time. And it has been damaged during childbirth, and maybe along the way with increase in weight, it has suffered a lot of trauma. So physiotherapy helps one to identify these muscles and to tone them. The more you tone them, the better the chance of women keeping their continence. Yeah, so it is a very, very useful intervention if done diligently. Next slide, please. What else? There's medication for kind of urgency, or what we call overactive bladder, which is incontinence with a sense of urgency. There's medication that you can have, very effective, and it's effective now about 70 to 80% of the women. Surgery for stress incontinence or leakage of urine with laughing and coughing is again very, very effective. Minimally invasive surgery, day case, tiny tape inserted in your vagina, again extremely effective, up to about 95% effective. There are other modalities such as Botox, sphincter injections, which are again smaller operations, so can be offered in women who cannot take a general anesthesia, etc. But now the advent of laparoscopic surgery and robotic surgery, and this has been available and easily available to this part of Chennai, with CURI being in the foray, has changed a lot in the in the management scenario, and is really, really very helpful for patients. Next slide, please. So a lack of pelvic floor tone causes prolapse as well. So what you see on the left side is pessaries. So when you ask me what else, if not surgery, because everybody's worried about surgery, and I don't know why. Like I say again, surgery is extremely safe now. So you do not need to be worrying about surgery, is my usual statement. But if you do want to try without surgery, then if a patient has prolapse, for instance, we try these pessaries. If the patient has stress incontinence, like we just discussed, we put in this tape, and they're very effective. What you see on the right is the tension-free vaginal tape for stress urinary incontinence. Next slide, please. So again, these are surgeries that can be done robotically with super precision, very little pain, short post-operative stay, and home in about 2 days' time. So the picture you see on your left is a sacrocolpopexy, again for a combination of incontinence and prolapse, a mesh beautifully stringed inside the tummy. So what you see at the bottom end of the gray structure is a vagina, and it's just pulled right up to a bony prominence in the pelvis. Yeah, the picture on your right shows another minimally invasive surgery for prolapse. Next slide, please. It is true, life begins at 50, and if you want to be anti-acid and say it's burnt out and spread out and falls out, we could be, but I think the best way forward is to get an assessment, get the treatment, and let's move on with our lives. Next slide, please.